seeing these cases, I think last week. This is a relatively unusual specimen. This is aspiration from a liver cyst. So in this cystic lesion, we do see some yellow, like crystallized pigment in the background. So this is the biopigment. So when we see this very special color and this kind of material in our specimen, we realize that there have some bio in the specimen. So it is from a liver cyst, so it seems to be quite usual. However, the background cell doesn't look normal. So we have a lot of single cells with hyperchromatic chromatin and these coarsely like a granular chromatin pattern with increased NC ratio. So the patient does has a past history of urothelial carcinoma, high grade. The cytomorphology is consistent with the high grade urothelial carcinoma. However, it seems that the patient had this cyst for a long time. So I think the cyst itself is not induced by the cancer, but it is involved by the tumor cell. So we stand for the GATA3, and it is positive for these markedly like enlarged cells. So this is metastatic urothelial carcinoma to a liver, to a hepatic cyst. So the next specimen is a pleural effusion specimen. The patient had the past history of gynecologic cancer. In this pleural effusion specimen, in the background we see a lot of inflammatory cells. However, we also see these tightly three-dimensional cell cluster, and when we go to higher power, we can appreciate the nuclear polymorphism. So this is markedly enlarged nucleus with prominent nucleolus and with a vesicular chromatin pattern arranged in a three-dimensional glandular structure along with phagocytosis. So this is metastatic adenocarcinoma, and the primary cancer is from the GIN tract. So this is likely the involvement by the gynecologic cancer. So again, this is high-grade adenocarcinoma morphology. The next specimen is from a peritoneal washing specimen. The patient is a middle-aged female, also had a history of endometrial cancer. So in this specimen, this is peritoneal washing, so you can see these larger fragments of reactive mesothelial cells. So reactive mesothelial cell may have some nuclear atypia, and you see there are indeed some polymorphism and even like small but distinct nucleolus. But overall, this cohesive flattened architecture suggests that it is actually a mesothelial cell instead of adenocarcinoma. So you didn't see the usual luminal glandular type of arrangement with three-dimensional architecture, but this is all very flattened. So this looks like a mesothelial cells. This looks like aggregates of histiocytes. And this tight cluster, three-dimensional cluster, looks very suspicious for adenocarcinoma. So when we see areas suspicious for adenocarcinoma, we would like to see if we can find some more prominent nuclear atypia. So in this cluster, you do see some more nuclear atypia. The nucleolus is not round. It has a very interesting triangle shape. And the chromatin pattern, this is all very vesicular. So this is much more likely to be metastatic adenocarcinoma. So again, this is very tight, very three-dimensional compared to the flattened mesothelial cells. And the cytoplasm, you see these vacuolation. The nucleolus, the chromatin pattern is also abnormal. And there are some larger cells in the periphery. So this is compatible with involvement of the cancer in the peritoneal cavity. So the next specimen is from a pleural effusion. This is the same patient from the prior specimen that we see, the inflammatory specimen, and with some three-dimensional architecture in the background. So this is from the same patient with different specimen, but again, this is metastatic gynecologic cancer to the pleural cavity. So you can also see the mitosis, brisk of mitosis just within this cluster of glandular cells. So this is positive for metastatic adenocarcinoma. The next specimen is a ascites specimen. This is also a middle-aged female, but she had a past history of colon cancer instead of gynecologic cancer. Again, in the background, we see a lot of inflammatory cells, and we see prominent drying artifact. So this is a cytospin preparation. Sometimes if we make the smear out of the cytospin, we need to fix it quickly. If it's not quickly fixed, it can cause some of these drying artifacts. So in the background, we see a prominent drying artifact. So those very faintly stained cells are likely mesothelial cells, and you also see the lymphocyte, the histiocytes. But here we see a much more preserved cell because it is more in a three-dimensional architecture. So it is less easy to get dry, and so it is much more well fixed. And when you go to the periphery, you see the chromatin pattern is not normal. It is very irregular. And the cells show these palisading feature. So this is compatible with metastatic colon cancer in the peritoneal cavity. So the next specimen is an aspiration specimen. This is a EUS, endoscopic ultrasound guided aspiration, but it is taken from esophageal lymph node. So it is a mediastinal lymph node sampling. So the specimen is obtained through transesophagus. So it is not a transduodenal or transgastric type of specimen that we usually see. So esophagus has a very thick muscle wall. So here we do see the sampling of the muscle wall. This is muscle wall, and this is very thick. So it is unlike the usual much thinner duodenal or gastric muscle wall that we see. So in the background, we do see reactive lymphoid population. So you see much smaller mature lymphocyte and some bigger one, from maybe central sites. So we see a reactive lymphoid background. And then we start to see some very interesting aggregates. Very interesting aggregates. And the cells doesn't have a very a clear cell border. It seems to be syncytial. However, the nucleoli are all very big and in a very strange shape, and it is cherry red, and it shows as well increased NC ratio. So this cell looks very atypical, but it does not looks like the usual type of cancer, such as adenocarcinoma or the usual type of squamous cell carcinoma that we see. So this looks like a poorly differentiated malignant cells. At the periphery, there are some spindling. So could it be a squamous cell carcinoma, but just very poorly differentiated? So when we check the patient's history, the patient actually had nasopharyngeal carcinoma, which is a poorly differentiated squamous cell carcinoma or undifferentiated squamous cell carcinoma associated with EB virus infection. So we does perform a cell block. So in the cell block, it's much easier to see these typical cells with these like a syncytial pattern and infiltrate by the lymphocyte. So the nasopharyngeal carcinoma is also known as lymphoepithelioma like carcinoma or lymphoepithelial carcinoma. So it's very easy to have the infiltration of the lymphocyte. So this is compatible with metastatic nasopharyngeal carcinoma in the mediastinal lymph node. So mediastinal lymph node is a very difficult area to sample. So nowadays we can use the endoscope for the sampling. In the old time, we need to do thoracic surgery. We need to do the video assisted like a thoracoscope and to collapse the lung and go to the mediastinal area and do the sampling. But nowadays, we only need to do it by the scope, which is much more easy, much easier. Okay, the next specimen is the ascites specimen. So the specimen, the cells are very, very scant. The patient had a past history of mucinous adenocarcinoma. So in these ascites specimen, we only have 2 or 3 cluster of highly atypical cells. So this is a very tight cluster, and the cell looks very different. It has abundant cytoplasm. So it has some bluish grayish material inside the cytoplasm. So these can be compatible with mucinous adenocarcinoma. There is a separate cluster again. The cell has very low NC ratio, but in these cluster you can see these are 2 different nucleoli, and very different in size, and there is a very prominent nucleolus over here. So this is also compatible with mucinous adenocarcinoma. So this tumor is very scant, but given the history and the morphology, I think we can just call it positive directly. So the next specimen is coming from a pleural effusion. The patient had a past history of lung adenocarcinoma, and this is the clinician suspect to have recurrence persistent disease. So in this specimen, again, the tumor cells are very, very scant. So we only see like a very scant atypical cells with vesicular chromatin and nucleolus, and arranged in a loosely attached, loosely cohesive cluster. So not a lot of tumor cells. So we do see these tight aggregate of atypical cells, but it's a little bit difficult to differentiate with the background reactive type of either mesothelial cell or histiocyte. However, when you take a look at these cells, you can see the nucleus is really big, probably 10 times bigger than the lymphocytes, and there is a cherry red nucleus, but with a triangle shape. It's very strange, and with an eccentric nuclear arrangement. So this is likely recurrence adenocarcinoma, and this one as well. This is a very tight cluster, but it is just very, very scant and a little bit subtle comparing to the background reactive cell population. So again, this is suspicious for adenocarcinoma. So in this situation, sometimes we will rely on the cell block. So in the cell block, we does find more prominent cluster with artificial cleft. So this is compatible with metastatic adenocarcinoma of the lung. So within this cluster, you can tell the nuclear polymorphism is very striking. So because it's very scant, the tumor population is very scant, so for sure, and the cell block is also very scant, but you can easily appreciate these cell population. So this is positive for adenocarcinoma, compatible with the recurrence of the disease. So sometimes the next patient is also a patient of lung cancer. This is a peritonean ascites specimen. So in this specimen, the ascites, I think the cell population is just very, very scant. And because of the cytospin preparation shows striking drying artifact, and also most of the cells are at the periphery only. So, so the preparation is not optimal. So it is very dangerous that we make a definite diagnosis just based on this type of preparation. So we can either to repeat the cytospin preparation. However, because we already do a cell block for these specimens, so there won't be a residual specimen for repeat cytospin. So because of these atypical cells that is highly suspicious for adenocarcinoma, but we don't have very good preservation of the cytomorphology, so we call these suspicious. So comparing to the prior specimen, we both had very scant atypical cells, but the prior specimen, because we have very good preservation of the morphology, we call it positive adeno, but this one, the cell block preparation is also very scant, so we call these suspicious. So the next specimen is from a pleura effusion. The patient had lung cancer, and this one is much easier because we have tons of tumor cells in the background. So we have this tight cluster, these very big of tumor cells, and again, the cells show prominent hyperchromasia and eccentric nuclear arrangement with vacuolated cytoplasm, and the cell cluster, each of the cells show different in size and shape. So this is metastatic adenocarcinoma, compatible with the patient's prior history of lung cancer. The next specimen is also coming from a pleura effusion specimen from a 70-year-old female, so she's relatively old. She had past history of breast cancer. So the breast cancer, again, sometimes can show a squamoid morphologic pattern. So like, for example, in this cluster, you see this cell in cell, like a hurling type of pattern. And the chromatin pattern is usually not that vesicular, but more of this coarse chromatin pattern. And sometimes these cells can also blend in the background. Yeah. So for example, I think this is a cancer cell because of this cell in cell pattern. However, it looks very similar from the background mesothelial cell. Okay, so this one is also a little bit difficult to appreciate. So the most important finding is that on low power, you do see some very tight three-dimensional clusters. So this is a good sign suggesting that there might be some metastatic lesion. So when you go to higher power, this cell cluster is very tight and three-dimensional. You need to focus up and down to see through. And also the chromatin patterns show coarsely hyperchromatic chromatin, and the nuclear shape is very irregular. So this is compatible with metastatic breast cancer. And for the cytospin preparation and for the cell block preparation, we do see these clusters. So this is compatible with breast cancer with a squamoid morphology. So the next specimen is also relatively easy because we have a lot of tumor cells in the background. So on low power, these might not look very problematic. However, when we go to higher power and we see these cells, although all single cells, but show prominent eccentric, like a signaling ring cell pattern, along with some karyoresis. So the cells show a lot of individual cell necrosis. So in this field, most of the cells are actually poorly differentiated adenocarcinoma with a prominent signaling ring cell feature. And these malignant cells throughout the entire specimen compose of the majority of the cellular population. And this is compatible with the patient's non-history of gastric cancer. So the patient does have a signaling cell carcinoma of the stomach, and this is compatible with metastasis in the peritoneal cavity. So finally, let's take a look of a couple finding the aspiration. So the first one is coming from a thyroid specimen. So this is a thyroid aspiration. So when we interpret the thyroid specimen, we will usually take a look of the low power to see the background. So we don't see any colloid in the background, but we does see like scattered larger fragments of cells. So we need to go to higher power to check if these are follicular cells or if these are other cellular population. So the cell itself looks not very typical for follicular cells. It has a lot of cytoplasmic process, so giving it a cis lining cell or a repair type of cells appearance. But the cell does show some elongation of the nucleus and some like loose chromatin pattern, a little bit like ground glass chromatin pattern, but we do not see any irregular of nuclear membrane or prominent nuclear grooves. So it does looks a little bit like cis lining cells, however, but the cells are slightly bigger than usual cis lining cells. So we were thinking that could it be a cystic change of a PTC or it is a cis with a cis lining cell, and we take a closer look, then we see here is a nuclear pseudo inclusion over here. So when you see pseudo inclusion in the cell population looks like cis lining cells, the diagnosis will be starting from AUS with cytologic atypia, and depending on your confidence level and depending if you can see some other cell population with more definite morphology. So again, here has very faint, small but clear pseudo inclusion in the nucleus. So we are thinking that it is suspicious for the papillary thyroid carcinoma, and we don't have more cell to interpret. However, we does see multinucleated giant cell over here. So here we do see multinucleated giant cell, here giant cell as well. Giant cell can be present in thyroiditis, in a hemorrhagic cyst, but can also be present in PTC. So I think the case is suspect to be a PTC with cystic change. Hence, you can see hemosiderin in the giant cells. So in the background, there are some cells with enlarged nucleus, elongation, suspect to be the PTC. So overall, we don't have a lot of diagnostic cells. This is the direct smear from the same patient. It shows more cells. However, we do not see like unequivocal PTC feature. So this is seems to be a histiocytoid, a typical histiocytoid cells, also with prominent pseudo inclusion. But the pseudo inclusion is not like the usual type that we see in the PTC. So overall, I think the specimen is highly suspicious for PTC, but it does not fulfill the definite criteria. So we will just call these suspicious. So we use the TBS category 5 to call these suspicious for PTC. And the management for these type of specimen is equal to the TBS 6 PTC, that if the clinicians seeing the radiologic and the clinical finding are consistent with papillary thyroid carcinoma, they will proceed to do the surgery. Nowadays, they turn to do lobectomy first instead of total thyroidectomy right away for smaller PTC. So this is basically what we see in both the liquid base and direct smear. So the next specimen is a parotid aspiration coming from a 75-year-old female. She had a very interesting clinical history that she said there is a mass lesion in the left infraauricular area for many years, and until recently it started to grow. So in this aspiration, we see in the background nothing, very clean, and we didn't see cystic component, we didn't see a lot of inflammatory cells, and we only see these larger fragments of highly atypical cells with a squamoid-like morphology, which is hyperchromatic and increased NC ratio and a little bit spindling. And the cell does show high-grade nuclear atypia, so you can see prominent nucleolus. It's even close to the size of the adjacent lymphocyte. So it seems to be a high-grade carcinoma, and so it is not difficult to call these malignant. So the most common scenario for these high-grade carcinoma in the salivary gland will be the salivary duct carcinoma or carcinoma X polymorphy adenoma with a salivary duct carcinoma morphology. So I think this is compatible with if the patient does has a prolonged history of a mass lesion in the parotid with recent growth, and it is compatible with a carcinoma X polymorphic adenoma. However, we do not see any polymorphic adenoma component in our aspiration. As what I said before, that breast cancer can look very squamoid. So salivary duct carcinoma is very similar to the breast cancer because they are all coming from a ductal structure, and it's very similar to the breast. So, so we were thinking about could it be a squamous cell carcinoma, or could it be just a salivary duct carcinoma with a very squamoid morphologic pattern? But overall, we can just call this paucity. So we use the Milan system. We say this is category 6 malignant, and we say that there's a carcinoma and with a high-grade morphology. So it is very important to denote that it is a high-grade carcinoma instead of just call it carcinoma, because salivary carcinoma can range from low-grade all the way to high-grade, and the prognosis is very different. So we need to address that this is high-grade carcinoma, and it can be compatible with salivary duct carcinoma, perhaps arising from polymorphic adenoma if in the right clinical presentation. So if you check in the textbook, most of the textbooks say that the most common malignant tumor in the salivary gland is the most common malignant tumor in the salivary gland in the textbook.
It's the mucoep.
Mucoep, which is totally wrong. And in our experience, the most common malignant tumor in the salivary gland is salivary duct carcinoma. And I asked Dr. Alina Skalova last year when we met in Bangkok. She also say in her experience is salivary duct carcinoma. And Dr. Abbas Agami was there, and he also said that it's salivary duct carcinoma. So in the old time, we don't have the molecular tool. A lot of salivary duct carcinoma with a little bit glandular or even mucinous differentiation, it will be called as high-grade mucoepidermoid carcinoma. But nowadays, we know most of the high-grade mucoepidermoid carcinoma are actually not mucoepidermoid carcinoma because it does not have the MAMO2 fusion. So the most common, I think in many, in Japan as well, Dr. Nagao also say that the most common is salivary duct carcinoma. So it's actually salivary duct carcinoma. And mucoep is not that common. And most of the mucoep are low grade. Okay? So this is all the case for today.